I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
Okay, we'll move on to the next patient. She's a 55-year-old postmenopausal woman that has triple-negative breast cancer presenting with really extensive metastatic disease, including leptomeningeal carcinomatosis. She was previously treated with neoadjuvant chemotherapy with dose-dense doxorubicin and cyclophosphamide, followed by paclitaxel and carboplatin. She had bilateral mastectomies and adjuvant capecitabine. So when we have a patient that's kind of presenting to us then with advanced disease, including leptomeningeal disease, Dr. Pegram, do you want to comment about what your systemic therapy of choice is in that particular setting?
Well, these are very, very challenging cases to treat indeed. First of all, I would probably do a lumbar puncture to see whether we can detect tumor cells by cytologic analysis in the cerebrospinal fluid. Not all patients with leptomeningeal carcinomatosis, however, will have positive cytology. But another use for lumbar puncture is to rule out other causes of leptomeningeal inflammation, for example, infectious causes. So just for completeness, I would probably do that. If she has positive cytology, it would certainly cinch the diagnosis. But even if she doesn't, then leptomeningeal disease can also be made, the diagnosis can be made with MRI imaging, even in the absence of cytology. In one retrospective analysis of 200 leptomeningeal disease patients, about half of them were diagnosed by MRI, about 23% by cytology, and 24% by both methods. I would also image the entire spine to see if there are, more than one area of leptomeningeal involvement in terms of the workup. That would be an important consideration. Now, sometimes there may be focal areas of leptomeningeal disease, and in particular, if they are symptomatic, they might be amenable to consideration of radiation therapy. So I would get a radiation consult if the leptomeningeal disease is focal, and particularly if it's symptomatic. The current standard of care for leptomeningeal disease, in addition to systemic therapy, would be intrathecal chemotherapy, such as intrathecal methotrexate, along with systemic therapy with or without localized radiation therapy. So if you just do a quick literature search, you'll find that that is the current standard of care still. Although this is a big undertaking if the cytology is positive and you choose to go the intrathecal route, because it's very labor intensive. It's tough for patients. They have to have an Ommaya reservoir placed, sometimes requiring treatment a couple times a week initially to get the early response. So it's not a trivial undertaking, and systemic options then kind of rise to the forefront, because if you can control the disease with a systemic treatment with or without radiation, maybe you could avoid the need for intrathecal therapy in a case like this. There are some clinical trials that are ongoing. The NCI has a clinical trial of sacituzumab govitecan in treating patients with breast cancer, brain metastasis, or recurrent gliomas. So if she's eligible for a trial such as that, that might be interesting. Also, you could check the PD-L1 status. There have been anecdotal responses of immune checkpoint inhibition with CNS metastasis. I would also check the BRCA status. There are case reports of CNS metastasis responses to PARP inhibition, for example, from the literature. And then finally, there is an interesting possibility to check her HER2 IHC. to determine whether she's IHC 1+ or 2+. As you know, there is some data on HER2 antibody drug conjugates, such as trastuzumab deruxtecan and SID985, that have impressive responses in these HER2 low patients, some of whom, it turns out, are triple negative. There's a very nice review in the JCO recently taking a look at this issue, and it turns out that about half of all breast cancer patients are HER2 low, and there are ongoing trials for these patients. Of course, leptomeningeal disease is excluded for eligibility for many of the trials, but you might be able to get compassionate use access to drugs like trastuzumab deruxtecan should she prove to be HER2 low as a future treatment option as well. So there's a lot of different things to consider in a case like this. I would check all of these tests like the LP, like the PD-L1 status, the BRCA mutational status, image the whole spine, rad-onc consultation. So right now, I would say it's going to be an extensive workup before we could make a final determination based on a balanced discussion with the patient and their family, what would make the most sense for them moving forward.
Thank you so much. I really appreciate that. Dr. Shaw, do you want to comment briefly on, sort of the role of radiation for the treatment of leptomeningeal disease and how you would approach this patient in terms of deciding if that would be a therapeutic strategy that would be meaningful for her?
Sure, absolutely. And I agree with everything that was said above. I would first make sure we have a complete imaging of the neural axis, including the brain. If the patient was having symptomatic disease and had kind of gross focal disease on imaging, I think local radiation therapy to those areas is important. One of the other things we typically do is we actually get an ophthalmologic exam as well, because in some patients that can be an area, and that impacts radiation fields because we can treat the back of the eyes as well in those situations. A common question I get asked in leptomeningeal disease for breast cancer is whether there's a role of treating the whole neural axis or craniospinal irradiation, and the answer is really no. It's extremely morbid in terms of side effects for patients and really has not been shown to improve outcomes whatsoever. So I would really limit radiation in this case to focal therapy where symptomatic.
Okay, thank you for that.